you, Chair. Good afternoon, colleagues. All protocols observed. So I will be presenting on the epidemiology of clients who do not initiate antiretroviral therapy within the same day of HIV diagnosis in two districts of Zimbabwe, namely Kwekwe and Tasa district, Nyamundaya and respectively. This is the outline of my presentation. In 2015, the World Health Organization released guidelines which recommended same-day initiation, which can also be referred to as rapid ART or treatment upon diagnosis, which refers to treating someone who's HIV positive regardless of their CD4 count or clinical stage. Same-day ART initiation, it carries both individual and public health benefits. At the individual level, it will lower the risk of HIV-related illnesses, as well as the risk of deaths, which can be attributable to HIV. And for persons with acute HIV infection, there's also the possibility of a functional cure. We say this when we focus most importantly on children who are infected during pregnancy and labor and delivery. If they are to be tested at birth and be put on treatment within the first 3 days of life, we do give them the hope of realizing full potential. It also carries public health benefits by reducing the risk of onward HIV transmission to sexual partner, as well as to biological contacts in the case of children. We also take rapid ART initiation as a catalyst to the attainment of the 395 UN goals. We analyze data from the 9 districts that we are implementing our HIV care projects in Manicaland and Midlands province. And we realized that 2 out of the 9 districts, namely Kwekwe in Midlands and Tasa district in Manicaland, it's suboptimal linkage. That is to say, of those that were tested for HIV, only 94% were subsequently linked to treatment on the same day of HIV diagnosis. Delaying ART initiation, it poses, like I said earlier on, some risks in terms of individual and public health concerns. We therefore conducted a study, and our study objectives, first objective was to determine the proportion of HIV positive clients not initiating ART within 24 hours of diagnosis in Tasa and Kwekwe district, and also to describe the demographic and clinical characteristics of clients not initiating ART on the same day of HIV diagnosis in the 2 districts, and to determine factors contributing to delays in ART initiation among clients testing HIV positive in the 2 districts. These were our study methods. We conducted an analytical cross-sectional study on clients who tested HIV positive but were not linked to treatment within 24 hours of diagnosis between October 2020 and April of 2023. This study was conducted in selected 20 health facilities in Kwekwe and in Tasa districts. And our study participants were clients of all age groups who tested HIV positive but were not put on treatment within 24 hours of diagnosis in the 2 districts. And we used routinely collected data, which was abstracted by nurses into Kobo Collect. Our data sources included OI-ART booklets, HIV testing services register, TB register, the presumptive TB register, and we analyzed our data using Strata 15 to generate proportions, measures of central attendance, as well as spread. The Cox proportional hazard model was used to measure the association between social demographic data and clinical characteristics with delayed time to ART initiation. We did seek ethical approval from MRCZs, and we ensured confidentiality throughout this study. These were our study results. The majority of the clients who did not initiate treatment on the same day were in the age groups 15 to 24 and 25 to 34, constituting 60% of the study's population. Males contributed 58% of the study population, and 48% of our study population were married. 40% of our clients or study population were people from the urban areas. 57% of the clients that we enrolled into this study actually were in WHO clinical stage 3, implying that the majority of the clients who did not initiate ART on the same day, they had advanced HIV disease as defined earlier on by previous presenters. And 19% of those who had a CD4 count, 19% had a CD4 count between 200 and 500. Whilst I said earlier on, we do initiate ART regardless of the CD4 count, it is still important to do a CD4 count upon diagnosis of an HIV status, so that those who are defined to have advanced HIV disease by having a CD4 count less than 200 will then be offered advanced HIV disease packages, which include TB, LAM, cryptococcal antigen screening, among many other things. We also did research testing, and 85% of the clients who did not initiate treatment, which is 91 of them, they were long-term HIV infections. However, 15% were new infections. 75% of the clients who did not initiate therapy on the same day of diagnosis was for the reason of TB investigations. 10% of the clients, that is 10% of the 91, they actually had cryptococcal meningitis. We went on further to do an analysis of the ART initiation. So we had 444 clients who tested HIV positive in these 2 districts. And out of the 444, 353 did initiate ART on the same day, and 91 did not initiate ART on the same day, which constitutes about 20% of our study population. Of those who did not initiate ART on the same day, we do take note that 22 did initiate ART within 1 week, while 17 did initiate ART within 2 weeks, 16 within a month. However, 14 clients never initiated ART at all. We then further analyzed the 14 clients who did not initiate ART, and we note that the majority, which is 6 out of the 14, they actually died, which is sad. 2 transferred out, and 2 were for because of TB investigation. We then went on to look at the risk factors for not initiating ART on the same day, and we note that having a male sex, it gave us a risk factor of almost double, twice likely not to initiate ART, which means men. I heard someone earlier on saying key populations, so maybe men they become to us a priority population. We also take note that TB investigations, if a client is being investigated for TB, they are 3 times more likely not to initiate ART. However, having advanced HIV disease is defined by having a WHO clinical stage 3 or 4, resulted in clients being more likely to initiate treatment. I think it's a no-brainer because they'll be sick anyway. Our study found that being a male and being investigated for TB were the most important deterrents to same-day ART initiation, and males with a higher likelihood of delaying ART initiation compared to females, which is in tandem with a number of local, regional, and international studies. Clients with a TB investigation had a higher risk of delaying ART, which is also in line with a number of other studies conducted in the region. Our study had some limitations, mainly because we relied on secondary data, hence we were limited on the variables that we could assess in our study. In conclusion, the independent predictors of delaying ART initiation on day of HIV diagnosis included being male and having a TB investigation. We do have some recommendations, and these include expediting TB investigations, particularly in rural and underserved areas, and to scale up the use of TB lab, which is a point of care diagnostic, which can be done by non-laboratory personnel in a primary health facility, and to expedite TB test results and implement mechanisms for immediate initiation of TB therapy upon diagnosis or suspicion. The earlier presenter mentioned issues around artisanal minors and them also having pneumoconiosis and silicosis, which also predisposes them to TB. We need to develop interventions targeting men, whom we agreed that they are indeed a special or a priority population for us, to be routinely screened for HIV and to have access to CD4 testing, and to increase awareness among men about the importance of timely ART initiation, as well as the benefits of early therapy, and to scale up psychological preparation of clients for treatment. I would like to acknowledge our funders, USAID and PEPFAR, as well as the Minister of Health, our study populations. Thank you.
Thank you very much, Dr. Nyamundaya.